Hello, everybody, and welcome back. For the moment, we are staying with the theme of COVID-19 for a symposium on psychological contributions to managing the COVID-19 pandemic. Once again, you can put your questions into Slido, and thanks so much for all the great questions there were earlier. They were really good. And I'd like to welcome back the president of the BPS and, of course, chair of the BPS COVID-19 coordinating committee, who's going to chair this session. Thanks, David.
Thanks, Claudia. You can tell Claudia's such a professional because she's only had such a short lunch break, but she's come back so organised. Whereas I had a longer lunch break, managed to spill my lunch down my shirt, fortunately below the camera line. But Claudia's completely in control, so that gives me great confidence. Okay, thanks. So I'm going to just give a brief overview of the work of the COVID coordinating group, and then we've got 4 individual papers. Now let me see, where am I? So I've got about 5 hours left of my presidency, and you think they might let me put my feet up on my last day, but not at all. I'm doing a symposium and then my presidential address. I think maybe they're trying to wear me out so that I won't ramble on later, but I'm going to talk now about the COVID crisis, and particularly the contribution of psychology. And I'll give you an overview, and then we'll go on to the papers. But and I'll also bring in Lane Whitaker, who is our diversity and inclusion champion on the group. I won't give you too much background at all about COVID, because I'm sure you've been watching and hearing nothing else for the last 3 months or so or more. But I think one thing that's just worth reflecting on is just how quickly COVID has become such a sort of huge global crisis. And this is the number of infections back in February, so just over 4 months ago. And these infection rates are counted in numbers, so 100 infections in the UK, sort of less than 20. And that was the picture on Saturday, 26th of June. Sorry, I was presenting in South America on Saturday, so that's why it's got a random bit of Spanish there. But you can see the scale of the effect of COVID across the world. Now these cases are measured in cases per 1,000 inhabitants. And so there's pretty much not a part of the world that has not been affected by COVID. And of course, the COVID pandemic leaves a real trail of destruction in many ways in its wake, and you can see that sort of most starkly in terms of mortality. And sadly, when we talk to international audiences, we realise and look at the international figures, we realise that the UK is pretty much at the top of the list of deaths from COVID at the moment. So Belgium, of countries more than 1 million inhabitants, is at the top at the moment, and we're second place with some other European countries behind us. So currently 673 deaths per million from COVID. The USA is a bit of a way behind, although New York State, and if that was a country and it's got well over 1 million inhabitants, that would actually be the highest country in the world at over 1,600 deaths per million. South American countries are some of the areas where COVID's rising, and China, where the outbreak started, is way down, so much lower than us at 3 deaths per million, and it really is a stark contrast with how the Chinese managed the outbreak. And at the time, the coverage in the press, as you'll remember here, the TV was quite sort of looking at it sort of quite sarcastically at China's response, but their deaths are far less. Of course, we're now reducing, the number of deaths are reducing in the UK, although certainly we're not out of the woods yet. Just this is just today that the lockdown where the BPS is based in Leicester has been tightened because of a rise. And of course, the problem is a world problem. And I was in an international meeting last night, and the German Psychological Society are presenting, and they quoted a participant in their study saying, "No one is safe until everyone is safe." And certainly the cases across the world are still rising. and the WHO said yesterday the worst is still to come. So when we started the COVID work in the BPS, we started thinking about what's the impacts of COVID and how can psychology contribute to minimizing those impacts. So we thought about them in terms of disease, the disease impacts itself, and particularly behavioural science and how it could prevent the disease, psychological care of people with COVID, psychological care of the relatives of people with COVID, and particularly the sort of particular circumstances around the pandemic, and bereavement support, and psychological well-being of staff, health and care staff. But then there's a whole set of wider professional and social impacts that we think that psychology can play a role in. We have to adapt psychological services, and also the effects of the pandemic on the general population in terms of confinement and socialization are significant, but also that's particularly it impacts even more on particular populations. We all have to, or many of us have to, work differently, and psychology's got a lot to contribute there. And also, and this follows on from what Steve was saying this morning about how coping with the crisis and reducing the effect on society is very much through community action and the resilience of community. So these formed our 8 streams of the BPS COVID response. We had some values embedded within the response that we identified right from the outset, and they were that we wanted to add value. We wanted to look at where psychology contributed specifically. We wanted to be based on evidence, bring practice and research together, collaborate across psychology, the discipline and profession, and respect and have a focus on diversity and promoting inclusion right throughout. I'll talk a bit more in my presidential address about how we did some of these things, because I've certainly learned a lot. That's our COVID coordinating group. Some of the members that you'll hear speaking in the papers are represented. I won't go through all of them, but those are the 8 work streams, and they representation from across the society, but from practice and research, from different member networks, real strength of bringing psychology together. Our diversity and inclusion champion Lane, you'll hear from in a second, when I stop rabbiting on, and some other members of the group, including Steve, who you heard from this morning. And also we had great support from the BPS staff. Key directors have been regular attenders at the meeting. So it's been really great to bring staff and members together in this work. So within these 8 streams, I'm pointing at my stream, that's what we help for. Within these 8 streams, there's groups of members and staff coming together within all of those, and that's what these look like. I've just pulled 3 out, 2 of which I played a contributing role in. This is the psychological care of relatives and bereavement one that was led by Nicola Rooney. And so there's been a whole raft of members contributing to this work. It's certainly been a huge team effort. The sort of outputs of this can be seen on the BPS website. If you go to the BPS website, there's the responding to coronavirus section, and they're split into professionals and practitioners and public. And that's the professionals one. You can see the latest we've focused a lot as things have gone through the focus changes. So now there's been some focus on return to school, returning to work. Initially was very much focused on hospital-based staff. And this is the resources for the public. And these are still being added to. There's still plenty of work going on, but I think overall there's at least 50 different outputs already. And the outputs have been really quite amazing, where the reach of this work, a lot of media, I'm sorry, this seems a bit focused on me, but these are photos I had of TV media interviews. I appeared on Radio Leicester twice, which was great. Dorothy Wade presented for the Colombian Psychological Society. The Royal College of Physicians wrote to the members drawing attention to BPS guidance, and I love this bit. He said, "This is a short and helpful document," in that order, short and helpful. And also the work has led us to be asked to contribute to lots of national initiatives. I'm myself involved in the development of the COVID recovery package for patients through the NHS. My colleague Amy Watts, actually on the conference as well, physiotherapist who's contributing. That's a really multidisciplinary project. So I'm going to stop my slide and ask Lane to come in and just share some thoughts before we move on to the other papers. Lane, are you there?
Yes, I'm here. Hi, David. Thank you.
So right from the outset, the very first meeting, and it's a rush to do these things, and I've seen it around everywhere, that people just get on with it and don't take a step back and think. And I was really grateful to the group that they all said, look, we need to embed diversity and inclusion. And we invited Lane, who's a member of the BPS Diversity and Inclusion Task Force, to come and play that role of not being the expert and not sort of having to know all the answers, but just helping to contribute to the process. So I don't know if you just want to share a few reflections on how that's been, Lane.
Yes, I have a kind of like one. I think initially it's just like it's been a privilege just to be a part of the group and get to know everybody and how everything works. So for me, it's been a privilege to have been asked. So thank you, David, for bringing me on board. But yeah, so I think that it's for me it's been amazing that to see the enthusiasm in the coordinating group, taking everything on board and embracing diversity inclusion in all of the work streams. Obviously there's still a long way to go for the BPS before we can say that they are fully representative, diverse, society, that they represent the whole of society. But making sure that diverse and disadvantaged groups are included should be embedded within the BPS, and hopefully that's something that is going to happen. So the coordinating group have thought about how they can include these diverse groups and unrepresented groups, and they've reached out and they have made this happen. They've included them in all the work streams that I've seen. For me, the one aspect is the deaf and hard of hearing community, because they've been completely just forgotten about and they haven't been included in mainstream media or any information. So for me, it's been really amazing that everybody in all of the groups have taken on board the effect of coronavirus on the deaf community, and they've put this in all the guidance so the deaf community will be able to feel included, and adaptations will be able to be made when dealing with deaf people. So I think it's been really great that everyone's made such an effort to make sure that they've really embraced diversity and inclusion, and from the start of all of the work to now, I've really see that come alive. So yeah, and I hope that the diversity and inclusion can carry on within the BPS as a whole.
Absolutely. Well, at 4:45, I'm going to give an overview of the BPS Diversity and Inclusion Task Force. So Lane will pop up again. That time we've got the video that you did, but yes. Lane's also been a link with the Diversity and Inclusion Task Force, who've sort of contributed to different aspects of the work. And one of the pieces of work that we won't talk about today, but I know that you were a link with, I know you've linked with a few different bits of work, but we're just doing some guidance at the moment, or it's just coming out about use of interpreters, haven't we? And
yes,
COVID, I know
that's correct. Yes, I have. I've been helping with that. So I've been helping Rachel and the group and just kind of put that together. So I was able to bring my own expertise as a British Sign Language interpreter. So I was able to put that into their guidance, just so that any professionals working with BSI interpreters, they know how to do that and what to expect, especially working remotely now that it's things are different, and just making sure that they know when to work remotely and the things that they shouldn't be doing remotely. So that's been really great. Yeah.
Great. Well, thanks for that, Lane. I just wanted to give people a bit of a sort of overview of the whole work stream, because obviously in these talks we're going to be focusing on particular aspects. We couldn't really have done talks on all of it, but I hope that's given people a bit of a flavour. And thanks, Lane, for giving that perspective. I mean, I think it's been really important to have that diversity and inclusion focus. I mean, it's not perfect by any means, and I always say to Lane that you don't need to be positive all the time. There's lots of things we can be doing better,
definitely.
But I think Lane's played a really, you have played a great role in linking and making us sort of more aware of it. So I think that's been really
I think it's positive, the fact that the BPS have embraced this, because obviously it's been much needed, and it's been a long time coming. So I feel like this is a really good start, and I think with everything that's happening in society, I think that will continue now, and I think that more places and more societies and are being more aware. So hopefully that this won't be the end of it. It will continue.
Great, thanks, Lane.
Okay,
I'm going to move on now to our first or our second paper, if we count that as a paper, to Angel Chater, who's the lead for the behavioural science and disease prevention Workstream, and is also the chair of the Division of Health Psychology. So she's going to talk about advising policymakers and public health on behavioural science and COVID-19 disease prevention. So over to you, Angel. Thank you.
Thanks, David. Oh, get my screen up. Okay, can you see my screen? Right, thank you. First of all, thank you to David for inviting me to be part of this COVID coordinating group. As he says, I'm leading the Behavioural Science and Disease Prevention Workstream, and I'm going to talk to you today about some of the things we've been doing in this workstream. Just to note also that alongside being the chair of the Division of Health Psychology, I'm also the chair of the Behavioural Science and Public Health Network, which I'm going to talk about a little bit today as well. So just some background into psychology's input in the kind of umbrella of behavioural science and public health over the last couple of decades. We had a secondment from the BPS to the government public health team where Susan Mickey and Nikki Rumsey added psychological input into different policies and white papers in 2003 onwards. And in 2007, NICE issued some guidance on behaviour change. And in 2008, the National Health Service for Scotland, Education for Scotland, worked with the health boards, led by Viv Swanson, to develop funded training in this area to help with their health targets, which is something we hope to have in the rest of the UK one day. In 2011, the House of Lords Science and Technology Select Committee held an inquiry on behaviour change, and 2 years later, Public Health England created a behavioural insights team to support that work. The same year, the BPS Division of Health Psychology and the Faculty for Public Health created a collaboration led by myself and Jim McManus to develop the Health Psychology in Public Health Network. And years that followed, we led some briefings on why directors of public health across the country need to have access to health psychology, but also the local government association issued a briefing on behavioural insights. This led to a webinar at Public Health England in 2017 on psychology's role within public health, and we highlighted the importance of psychology and behavioural scientists to be able to help analyse literature, systematic reviews, to advise on policies, programmes and communication messaging, to help design interventions and programmes and support research trials, and also to upskill those who are working within public health on psychology's input to it. This led to a strategy document launched from Public Health England with the BPS as a key stakeholder in September 2018. And at this time, the Health Psychology and Public Health Network was renamed under my term as chair to the Behavioural Science and Public Health Network to support the implementation of this strategy and to create a community of practice where we created localised hubs across the country to be able to link psychology, behavioural science and public health together. In 2019, we led the BPS Senate campaign proposal on prevention, tackling a key government priority. And although we came second to poverty and flourishing, which is an incredibly important thing to focus on, we continue to work within the prevention agenda. And then of course COVID-19 happened, and we were already working closely with public health, and public health began to be the forefront of topical conversation and push the prevention agenda up. So in March, a group of us who were already working within public health had tweeted that we're going to create an open science framework where we would collate all of the psychological knowledge that we could get our hands on to support the COVID response, to stand in solidarity with our NHS and our public health colleagues. And we did this through something we called the Health Psychology Exchange, or the HPX. And this was led by the past chair of DHP, Jo Hart, myself as current chair, and the chair-elect, Lucy Byrne-Davis. At the same time, David had tweeted about his map that he just showed you around how psychology can support the COVID-19 pandemic, and he invited me to be part of the COVID-19 coordinating group. And as we know then, you know, the same day actually that all of this was happening on Twitter, the UK then went into lockdown. So from here, we collectivised a group of psychologists from across the BPS, from health psychology, clinical, counselling, sport and exercise, occupational, from the social section, the addiction section, and many other different realms of psychology, where we brought people together into this work stream, and they also had different cross-stakeholder hats on. So we had representation from people who sat on SPI-B, on the Behavioural Science Consortium, on the Psychological Professions Network, within local authorities, and so on. And this group, alongside the wider group of the Health Psychology Exchange, began to work on how we can support the COVID-19 response through psychology. Now, what we know is psychologists are scientist practitioners who are equipped with understanding behaviour and behaviour change. So we knew early on in this pandemic that without a vaccine and without a cure, infection control has to be via behaviour. But it was a new virus. It had many unknowns. We didn't have research to draw on from this particular virus, but we knew how to ask the right questions based on our methodologies and our theories that we have. So our core mission was to bring to the attention of policymakers, public health teams and communicators the things that they don't know, which we felt that they should know. So our aim was to build capacity through translation of a core piece of guidance to use behavioural science in the prevention of infection and disease management during COVID-19, and to support capability, opportunity and motivation for them to engage in informed decision making, campaigns and messages that are informed through psychology. We also wanted to provide psychology volunteers who had an expertise within health and public health to support this acute phase of COVID-19 through the Division of Health Psychology and the Health Psychology Exchange, which was a collaborative hive of people who could offer their expertise, with the ultimate goal that everybody has to save lives. So our core piece of guidance was launched on the 14th of April, a couple of weeks into lockdown, and it had 9 key considerations for policymakers, public health teams, and those who could use this guidance. And I'm going to talk these through one by one. First, to minimise the I and emphasise the we. We heard earlier on from Stephen how important it is to create a collective viewpoint, and our social psychology colleagues, John Jury, who was on our group, really highlighted the importance of messaging and how we need to show that we're in it together, and that we need to engage in behaviours as a society for each other rather than being out for ourselves. Second, to deliver messages from a credible source in relatable terms to a target audience. So we highlighted the importance that public needs to trust in the policies, the strategies, the information and the guidance that's being given to them, and that the messenger who's giving that information needs to be deemed credible. So the message needs to be relevant and it needs to be achievable for that target audience. And what we've seen through surveys through the University of Oxford and the Reuters Institute, that actually the trust in the government has dropped, particularly from April to May, both in the government, in politicians and in news organisations. And the impact that has is people who have less trust are less likely to engage in behaviours that we know are important, such as self-isolation. Our third was to create worry but not fear. We knew from previous research on other pandemics such as swine flu that the uptake of personal protective behaviours such as hand washing and social distancing were linked to a lack of public worry. And so we knew that the public worry needed to be evident, but not so much that it induced so much fear that people then disengaged with the message and it led to denial or avoidance. And we know from previous work with public health fear campaigns such as smoking cessation, using models such as the protection motivation theory, that if you have an elevated level of threat, you also need to have an elevated ability to deal with that threat through a coping appraisal. So we highlighted the need to identify what needs to change and the drivers of what needs to change in terms of what influences behaviour. So we used a well-known model, COM-B, and we highlighted that individuals need to have capability to enact a behaviour. So this is knowing what to do, knowing how to do it, so knowledge, skill. Also remembering how to do it with memory and behavioural regulation. They also need opportunity to enable the behaviour. This comes from societal norms, physical resources, our social influences. So we needed to highlight that people need the opportunity, for example, to be able to wash their hands in the environment that they're in. And also motivation to perform the behaviour. This comes from desire and habit, how we deal with emotions, our beliefs in our ability to do something and whether it will lead to a positive consequence. And on the 16th of May, the British Journal of Health Psychology published a paper that showed that this model does predict the behaviours linked that we're discussing within a COVID-19 outbreak. Fifth was to clearly specify behaviours and their effectiveness. We highlighted the need for clarity so that we avoid confusion and unintended consequences. So people need to know what they need to be able to do it, and this needs to be clear. And we also highlighted that where official messages for behaviour needs to change over time, a clear rationale for why that needs to change needs to be given, and a new set of actions that are clear need to be provided. And what we know from research with medication adherence, for example, is when people have a low necessity, they don't believe they need to do something, or they have a high concern about subsequent consequences, they're sceptical of the messaging to engage in a behaviour, and there's low adherence. We also highlighted the need to avoid unintended negative consequences. So these are things like increased anxiety, widening social deprivation, or social isolation. So we highlighted the need to know your target audience to avoid inequality. And a good example was when the guidance was, when we were in lockdown, you can go outdoors for one form of outdoor exercise. But there was messages like such as in the garden or in green space. And when people were going to green space, they were then almost being told off for everybody going to a green space, but perhaps considerations of where populations don't have the opportunity to go into their garden weren't actually considered. So we highlight that while we're all in the same storm, we're not all in the same boat, and we need to consider these different factors. Seventh, to create clear channels of access for health literacy. We know when our anxiety is heightened, cognitive processing can be challenged, we can feel overwhelmed, and it's difficult to take in information. So again, we highlighted the need for clear communication that's accessible, credible, and reliable. And 8 and 9 was to use behavioural science, to use the psychological evidence, and to work in a multidisciplinary way to combat COVID-19 together. We've had eminent psychologists such as Susan Mickey and Lucy Yardley speaking to the government within SPI-B, within SAGE, within the House of Lords, and many others engaged in this. But we also wanted to create a pipeline to connect professionals on the ground and organisations with psychological expertise during this acute phase. So we created, through the network of volunteers through the Health Psychology Exchange, individuals who could give advice on policies, strategic development, rapid reviews and evidence synthesis, and how to develop interventions and upskill others in psychological approaches. And we did this through the Division of Health Psychology email list that linked with Lucy Byrne-Davis, who was also managing the Health Psychology Exchange and has been incredibly busy over this period of time and deserves the medal, in my opinion. So we then began to translate this guidance into public health teams across the country via weekly forums. So we would meet on a weekly basis with a number of representatives in local councils and within the NHS and other different organisations. And they've told us that they're using this guidance as their Bible. They're going through each point to make sure that any type of messaging, where they're putting street signs, etc., etc., these things are being considered. And they come to us and they say, can you give us some advice on public health messaging? And so we have done a rapid review on this. And they also ask, we need guidance on behaviours not linked to COVID, but impacted on it, such as diet or exercise or sleep. And so we're working with the Working Differently stream and the isolation stream to produce some documents on that also. We've built capacity by a request through the NHS Health Education England, linking in with Public Health England and the Behavioural Science and Public Health Network to deliver a webinar which talked about this guidance and how to implement it on the ground, which we delivered on the 15th of June. And we've had this guidance accessed over 5,000 times through the BPS website, 34,000 times it's been impressioned on Twitter, it's been referenced twice in SAGE documents, and as a collective, we're an approved source for information for SAGE and SPI-B. We've had members involved in radio and TV interviews, and we've collectivised over 113 psychology volunteers. We've responded to 17 requests from organisations, held 2 webinars and have 2 coming up. We've done 2 rapid reviews, which are in preprint. One of them led to another briefing on Contact Digital Tracing app and how we can ensure the psychology goes into that. And we have another one on the public health messaging that we will also translate into a briefing in the near future. We've also had this guidance translated into Japanese. But we still have work to be done. The clarity of the messaging through government and the trust in government needs to be strengthened. Early on in lockdown, the message was clear: stay at home is a behaviour, protect the NHS is a reason for that behaviour, and save lives was an outcome of that behaviour. But that messaging changed to stay alert, wasn't clear what that was. Control the virus, wasn't clear how that was going to happen. Save lives, wasn't clear whether that was actually going to lead to it. So not following the science or deterring from it can lead to the chaos and confusion we saw around that message changing. And there seems to be a disparity between scientists and politicians that's growing. Hopefully going forward, the Psychological Government Initiative can support continued development in this area. It's being led by the BPS Central Policy Team. There's 8 psychologists on a steering group, and 2 of them are within the task force that I've been describing today. We hope to co-produce outputs and deliver training to MPs and civil servants to amplify the voice of psychology within government. And there's an urgent need for a Chief Psychological Officer. So we still have work to be done. I just want to end by saying thank you to the huge number of people who've been involved in this project over time, and just to hope that we continue in this collective efficacy.
Great, thanks, Angel. There's so much going on there, and I know you've done quite a lot of work yourself, and it's amazing that you've contributed to other work streams as well, but I know you've got that army of people supporting the work as well, so it really is quite amazing. So thanks so much for such a comprehensive presentation. We better move straight on to the next paper now, which is Ingram Wright, who has been working in a subgroup of the adapting psychological services. There's been a number of challenges to provision of psychological services, and one of the particular ones that caused particular sort of issues was in relation to psychological assessment, and some psychological assessments that needed to go ahead for various really important reasons, and how we could manage with the remote working. So Ingram very kindly agreed to lead a piece of work across the society to bring people together from different backgrounds who are sort of facing the same kind of problem. So I'll pass over to you, Ingram.
Thank you, David. Thank you, Angel, for an excellent presentation. It's good to hear that we're influencing behavioural science at so many different levels. So I really appreciate your talk. I'm going to take a slightly different tack and focus on the content in a fairly narrow area, but I hope it strikes a chord with the audience. So I've been asked to talk about some work we've been doing as part of the COVID work streams on undertaking reliable and valid, which is the original title, psychological assessment. But I wanted to add safe and ethical, because the key principles here about how do we deliver safe and an ethical assessment in the current context. I'm just getting used to, so I've got some people to thank. David, thank you to you for helping to coordinate such an effective, and to Roman for coordinating an effective sort of cross-divisional position on this, and there's a whole host of other people from across the BPS who've been tremendously helpful, including Hannah and Sonarica within the BPS itself. So the world has changed in terms of how we interact, how we learn, how we conduct assessments, how we conduct teaching, and I don't need to remind you of some of the challenges we faced in this regard. This is a Rembrandt painting showing a surgeon demonstrating to a group of eager learners how to do something. I'm not quite sure what he's doing, but I'm sure that people are keen to learn. The learning experience on Zoom is rather different and rather more challenging. And so is this conference presentation. I know there are lots of you out there, but I can't see you. We've all had this experience of being on Zoom, of trying to interact remotely, having conversations with people. You can't see the joke on the right hand side. He's saying, I'm only dressed from the ruff up, which doesn't quite scan, but I guess you get the picture in terms of some of the challenges we face in turning this kind of learning experience into something that is rather different. In terms of meetings, I don't know if people have seen this video. It's a really useful way, I suppose, of thinking about some of the challenges that we've experienced, certainly in terms of using online remote tools that can be deployed for use in assessment. So this is a meeting just trying to mimic what real life would look like if we experience the same kind of challenges we experience in Zoom meetings and other platforms, with people dipping in and out spontaneously, not introducing themselves, not being able to be heard. So we're all used to these challenges, aren't we, in our personal and professional lives? And the task that we were set as a group was to look at reliability and validity, safety and effectiveness of our assessment processes as practitioners within various parts of the BPS. And I just want to remind you, not because I think you've forgotten, but because it's helpful as an orientation, what reliability and validity are in relation to assessment. So reliability refers to the consistency of our measurement. So if we're conducting an assessment or a measurement of any kind, we want to make sure that when we repeat those assessments over time, assuming the baseline construct hasn't changed, that we get the same results. That across different items that are sampling the same behaviour, that we get consistent results. And that when different researchers undertake the same assessment, they achieve the same findings with the same individual, with the same underlying presenting construct. And validity is related to this. It's contingent upon reliability and is based on to what extent is this evidence convergent with other sources of evidence, and to what extent is this source of evidence or information about an individual or their underlying psychological construct discordant with things we would expect it to be discordant with. So you know what those things are, but I think it's really important to remind ourselves of what we're doing when we're undertaking a psychological assessment, because that kind of analogy or those kinds appealing to the underlying fundamental pillars of our assessment is helpful in guiding whether that assessment is indeed safe and effective. So this picture shows a head circumference. This isn't a live child. The child looks slightly odd, but this child is having their head measured, and the person undertaking the measurement is being taught to undertake that measurement appropriately. You can see probably if you look closely, there's a slight bowing in the measurement tape. If you don't pull the tape tight enough without hurting the baby, that you won't get an accurate measurement. And so there's a degree of variability, even if the head size remains static, as indeed it would within short intervals. So we can measure a baby's head circumference. The circumference of the baby's head has clinical implications. If a baby's head doesn't grow, it may suggest some underlying condition that needs urgent clinical attention. Equally, if the head grows at a faster rate than expected, it may indicate some underlying sinister cause that again requires some kind of intervention. We can make mistakes, and we do make mistakes. We can make mistakes by measuring the wrong body part. So we might measure the baby's arm circumference rather than their head circumference. We might do this, it might seem ludicrous, but we might put the numbers for the arm circumference into the head circumference box. So there may be transcription errors, all kinds of clerical errors, etc., can contribute to the variance in the adequacy and the reliability of our assessment process. We can mix up the babies. We can measure the wrong person. We can assess the wrong thing in the wrong individual. So there are all kinds of ways in which we can make errors. And sometimes the errors that we make are catastrophic. So this is the Tay Bridge having suffered an engineering catastrophe and fallen into the river with consequent loss of lives. The point I would want to make is that the cost of errors depends upon the context. So I often use this example in teaching. Is 36.4 significantly lower than 38.4? Now, numerically it is, and indeed within the error of measurement with the average thermometer, you could reliably distinguish between those two temperatures. Now, in terms of context, if this refers to the temperature of your bathwater, the distinction is largely trivial. So in terms of its meaning, it has very little bearing on the comfort or otherwise with which you experience your hot tub or your bath. However, as all of us know who've been measuring our temperature daily with various kinds of thermometers know, a 38.4 would be indicative of a fever. may be indicative of an underlying infection process which requires medical attention, whereas a temperature of 36.4 in a young child would be essentially normal and wouldn't require the same degree of medical response. So the meaning and the clinical significance, if you like, is distinct from statistical significance. And what we need to do is to understand the context in which those distinctions become meaningful and herald risk. Okay, so in terms of remote assessment, we need to consider how our diagnostic processes are required to be reliable and valid. So we may want to undertake a diagnostic assessment for legal processes to get someone access to the services that they require, to ensure that children get appropriate provision for educational needs based on their underlying specific learning disability. We might want to support people with regard to career advancements in occupational psychology and make sure that psychometric assessments that form the basis for that are undertaken appropriately and in a timely fashion. We may, as I've already illustrated, want to ensure that people get appropriate medical treatment in response to their diagnosis. Now, remote assessment has something to offer here, and particularly in the time of COVID, because we're unable to undertake safely and effectively face-to-face assessment. The benefits of remote assessment are therefore that we reduce the infection risk. We can potentially give access to people with much shorter waiting times. Patients, if they're attending NHS clinic, don't have to travel quite so far, and we in Bristol have patients travelling 150 miles to attend some of our clinics in a conventional face-to-face clinic. There's reduced time for the clinician in terms of setting up the clinic. There's reduced cost, and we have to think about the trade-off between Zoom licenses, for example, and the physical infrastructure costs of maintaining, say, an outpatient clinic in an NHS hospital. But there are some key questions about accessibility. It's not clear to me that remote assessment is as accessible as face-to-face assessment equally across all groups. It may be that those of us who don't have webcams, those of us who don't have reliable bandwidth, may be disenfranchised from systems that overly rely on remote assessment. There are costs of remote assessment, and the key consideration that we had as a group was around the compromised validity with the assessment process. We have severe constraints on how we can use materials, how we can engage in carefully timed interactions, and we have broader compromises in terms of the way in which we can present visual materials. And I'm looking at my slides here and notice that the right side of my slides is obscured. It may well look the same on your screen, and it may well look the same to someone who's trying to engage with that material at home and respond to it. And I need to be careful that what I can see on my screen is the same as somebody can see at home if I'm using that as a basis for my assessment. There's also a question about privacy, and I've had one or two examples where people have invited me into their homes on webcams, and I've been concerned about their family dynamics, or I've been concerned about the interactions between the parents and the children, but I've also been concerned that there is a risk that we are exposing ourselves in terms of our domestic environments to clinicians in a way that's not properly regulated nor fully understood by the clients themselves. We've done some brief surveys, and the numbers here aren't huge, but essentially we've been doing far less inpatient work in my NHS service. But when we've looked at remote clinics, it's clear that people are saying to us, when COVID is over and we're able to engage in more conventional access to outpatient service from a treatment point of view, people are very keen to have a blended model and not a wholly remote model. So that's just some interesting data, I suppose, in terms of what our clients are saying to us about their outpatient experience. We've produced 3 documents, the first from the Division of Neuropsychology on assessment undertaken remotely, which is specifically about neurocognitive assessment. Considerations, this is from the Division of Clinical Psychology, DCP, Children and Young People's Faculty, on considerations for psychologists working with children and young people using online video platforms. And finally, the document that I'm talking about here, which is about psychological assessment undertaken remotely. All of these documents contain guidelines about how we should undertake assessments and how we can ensure they're undertaken in a reliable and valid way. The factors which limit the reliability of an assessment are a multitude of client-related factors, psychologist-related factors, environmental variables, factors related to the assessment itself, and of course, corresponding constraints on the interpretation. I'll go into some more detail later, but I'll skip forward just in the interest of time. So in terms of examiners and examinees, they both need to know how to do assessments wearing PPE, if they're going to do that remotely. Of course, conventional face-to-face assessments look like this. Now, not all of you would feel comfortable being assessed by a psychologist wearing PPE, might not feel as open, the interaction might not be as fluent. The psychologists themselves may not feel able to make judgments about the client's responses or reactions to certain things in a way that would be as valid as it would be without wearing PPE. So there's no option, certainly in terms of our present practice, to have a face-to-face assessment which is conventional and consistent with the circumstances in which the assessment was validated. So we have a choice between PPE or a similarly, differently compromised assessment undertaken remotely. We need to consist the risks of assessment in person versus remote with reference to infection, equity of access, the choice that patients need to make, the security of the tests, so whether those tests leak into the public domain, which invalidates them and means that they're so universally understood that they no longer have the psychological potency that they need to have. The evidence suggests that if we look at the distinction between different forms of assessment, such as UK versus UK normative data, that the effect sizes, that's what these D values are relatively small. If we translate assessments from paper to an iPad, again, the effect sizes are relatively small. And so we can be reasonably confident that there'll be a strong correlation between assessments in the UK versus the US and assessments undertaken versus in the iPad versus a paper format. So we know that assessments can be deployed in different modalities without necessarily threatening their validity. This is a paper just focusing specifically on neurocognitive assessments, just showing there is a range, clearly different domains of assessment and a range of corresponding adequacies in terms of the performance of individual tests and the correspondence, the construct validity and convergent validity with face-to-face assessment. We've done some similar work using Zoom as a platform, using Attend Anywhere as a platform, which is an NHS tool which we've purchased to do screening assessments for young children with cognitive disability. So just to give you a little bit more detail about some of the client, psychologist, environment, assessment and interpretation factors. So we know, hello David, we know that that age is a factor. So I naively thought that young children would kind of love Zoom and they would be fine doing assessments on Zoom. But what I've discovered, and this is rather anecdotal, is that just like I am, that some children become so obsessed with their own image on the screen that they're unable to look at me. Some children feel that Zoom meetings and FaceTime is a way of interacting socially. It's not something you do with unfamiliar adults. So I think have felt a degree of discomfort interacting with me on a webcam, as they might quite rightly should. So I think that some of our superficial judgments about how age might be a factor in relation to engagement are not necessarily borne out, certainly in terms of my experience. And I think the issues are somewhat complex and we need to more fully understand those. Those with learning disabilities, sensory information, processing difficulties, communication skills are also going to be adversely affected by this modality of delivery. We need to think about the psychologists. We're not all equally skilled, and I've certainly learned a lot about using Zoom and Attend Anywhere, but I'm by no means fluent in terms of using it for assessment. And I think we have a responsibility to make sure that we're up to the job in terms of our skill level and make sure that we're familiar. There are issues, as I've discovered in my domestic environment, with bandwidth, lighting, distractions in the home environment that can perturb the interaction with a client. There are no doubt constraints about the type of assessment that we can conduct, and these are things that we need to properly consider. But there are also in quite significantly constraints on the interpretation, and this is where the issue of risk comes in. A number of divisions and associations have indicated that we need to be very careful about making diagnostic judgments using flawed assessments or constrained assessments with online delivery. I'm going to skip this slide, David, because I know we're short of time, but I just want to finish with what's for me the most important point and the culmination of our document, which is that any assessment conducted in any way needs to be clear about the manner in which the assessment was conducted. It needs to be clear, in this case, it was conducted via a video link, and in some circumstances that will constrain our ability to safely make appropriate and valid and reliable judgments about the way in which a person presents. And what we can do in order to safeguard our professionalism is be clear about what we believe those limits are and ensure that we manage safely and effectively the judgments which are made on the basis of our assessment. Thank you very much.
That's fantastic, Ingram. Thank you. And I mean, that's such a comprehensive piece of work, and I think it's this piece of work, particularly to me, really illustrates the benefit in bringing people together from their different areas of practice. Within neuropsych, I mean, people have been thinking about this, but I know you've worked with psychologists, from educational psychologists, people working in intellectual disabilities. I know there's lots of people that are facing these issues, and it's just been really great to bring people together and identify the common themes, which are often quite similar across, what seems to be quite different areas of practice.
Yes, thank you very much, Dave.
Well, thank you for that, your work, and for that fantastic presentation. We'll move on now to the next presentation is from Vivian Hill, who's been leading the effects of confinement and social isolation stream, which is a huge stream within which a huge amount of work has gone on in very different areas. And today it's been really interesting within that to look at some of the common themes. And I know Vivian's, is that your slides up, or Ingram's still up, Vivian? Oh, are you? Yeah, okay. Vivian's going to be talking today about the psychological perspectives on transitions during the pandemic, and that again is a theme that goes across quite different populations. So I should have mentioned that Vivian is, as well as her day job as the director of the Doctorate in Educational Psychology at the Institute of Education, is also the chair of the Division of Education and Child Psychology. So she's a very busy person. So I'm incredibly grateful for all the work that she's done and for her presentation today.
Thank you.
Are you ready to go?
Yes,
great.
I'm ready to roll. Well, what I wanted to say first of all is, yes, this has been an enormous work stream within the context of looking at the impact of confinement and social isolation. And I've been supported enormously by colleagues from across 10 different divisions and faculties, but very much in particular by Alison Crawford, who is the Principal Educational Psychologist in Glasgow and the Chair of the Scottish Division of Educational Psychology. We've worked very much in partnership with this piece of work. And what's been fascinating is the narratives that develop when you're meeting and discussing across different strands of psychology. And what I hope to present today is some of those developing narratives. So the main focus of our work really has been thinking about supporting transitions. As we know, the impact, the sudden impact of the COVID lockdown on society was probably one of the largest transitions made across the whole nation in a very short time frame. And what was interesting is within the Division of Educational and Child Psychology, within 6 hours of the announcement that schools were going to be closed, colleagues had come together to produce a paper to support schools in the processes of closing and shutting down, and just thinking about who were the vulnerable people, thinking about the setting up and running of schools, because as we know, schools have remained open throughout the pandemic to particular populations of children and young people. And I suppose in thinking about transitions, you have to acknowledge that it's a time of risk and opportunity for people. So they provide opportunities for huge personal growth, but they also pose threats and challenges. And I suppose with something like COVID, this invisible virus that many people who have it are asymptomatic, poses huge risks to us as individuals, but really the greatest risks are to us as part of society. So within our group, we were conscious that we would need to be thinking about how this was impacting on absolutely everybody in society, all ages, all communities, and all needs, and pulling together from across the BPS, the relevant psychologists to help us think about what were the messages, who were the groups that we really wanted to target. We drew on a huge range of psychological knowledge, skills and expertise to really think about not only providing guidance for particular groups and populations, but to think about having an impact on policy and thinking about how to influence government in terms of thinking about the processes of adaptation and change. I have to say that we've been very envious of the systems that exist in Scotland, where there seems to be very close collaboration between government and professional networks. And sometimes one can't help but think that perhaps some of our processes of change, particularly relating to the closing and the reopening of schools, might have been better if more thought had perhaps been given to the processes of managing that process. And again, it was really about thinking about offering support to the breadth of communities and populations that were being affected by COVID. And I suppose the most stunning part of this was the speed with which knowledge was being developed and generated as COVID progressed through society, as statistics gave us information to understand that actually the impact of COVID was quite different in different communities and different populations. And we certainly drew on a wide range of psychological theories when we were thinking about how to organise and structure advice and guidance, and really where to target it. So this is Bronfenbrenner's bioecological model, and just thinking about across the different systems that humans populate. So starting with the individual, then thinking about their microsystem, the home, the family, the workplace, school and peer groups, how those interactions have huge impact on an individual, and particularly when you're thinking about disease prevention and thinking about risk and transfer of a virus, you have to think very carefully about how those systems are managed. And then moving out through the other systems, so thinking about the processes that interact between those various different contexts and systems. And I suppose at the outer level of the concentric circles, thinking about the macro system. So this is really thinking about government policy, government structure, processes for supporting change. And interestingly enough, within this and across these different systems, you have to look at differentials in terms of increased risk factors for some individuals and populations, but also resilience factors. I think within the social isolation group, we were absolutely determined not to pathologize people, but to actually think about actually anxiety and worry are appropriate responses to such a horrendous disease, which is having such a huge impact on the population. So really thinking about how to enhance the resilience and to really think carefully about what psychology has to offer in these different environments. And I suppose we really saw the power of psychology in a pandemic, the ability to be able to strategically offer psychological insights to government and government departments, to highlight what we understand to be effective processes for the management of change. So, for example, including opening and closing of schools, but actually thinking about how do you get the best outcomes. We've been very keen to highlight the message throughout all of the pieces of work we've engaged in, that this isn't about me, it's about us. It's about shifting the way people think from a very individualistic perspective to recognizing how they impact on one another. So thinking about multiple and multidimensional transitions theory, how a child being excluded or no longer being able to go to school has an impact on everybody in the family, perhaps those who are shielding, grandparents, parents, their ability to work. So really thinking through dimensions of impact. We were really keen to think about highlighting through policy statements the needs of vulnerable groups and populations. And as I say, as we progress through this pandemic, we have really discovered some extremely concerning issues which seem to interact with wider movements across society. So, for example, the Black Lives Matter movement. We were struck by the tremendous interlinking with the BPS Poverty to Flourishing policy campaign this year. And just thinking about, as we were planning for things like the return to school, just becoming aware of the huge inequalities that existed in terms of access to education during school close down. By the end of May, the Institute of Physical Studies had identified that children who had access to the internet had probably had almost 7 full days more educational uptake than children who were relying on a shared device. We were conscious of children in families where perhaps the only device was a mobile phone. And of course, those where there was no contact, no internet access at all. So using the power of the BPS to raise these issues and make these challenges. We also were keen to be offering direct and effective evidence-based support to vulnerable groups. And that's where the being able to reach out across the breadth of the BPS to all of the different divisions and faculties meant we were able to offer really helpful guidance to particular groups and individuals. I think the other thing that really emerged through this process was just the importance of our social context, both on our behaviour, but also thinking about how multiple factors interact to impact on people's likelihood of contracting COVID, but also the likelihood of people dying of COVID. And over time, the data sets were revealing some really quite uncomfortable truths about the huge social divides in modern Britain, that the risk of mortality in the poorest communities was actually double that of our richest communities. But going even further than that and looking at the risk of mortality for some of the BAME communities being double that of the white population. And clearly what we were uncovering was a much more complex model of understanding of this virus, where we were able to recognise that, of course, underlying health issues were a key variable in all of this, but actually other variables were just as significant. So considering occupation, poverty, people living in overcrowded living conditions, multi-generational family context, and geographical location all had a significant factor. And I think what was key to us was trying to help people understand risk and really helping people to move away from thinking about me to thinking about us, that what I do doesn't just matter for me, it matters for everybody in the systems and contexts that I'm part of. And I was struck by this sort of poster that claimed that COVID-19 does not discriminate, because what the emerging evidence base seemed to be suggesting was that actually it really did discriminate. And there was a lot of talk about we're all in the same boat. But actually, when you looked at the statistics of some people were able to work from home and continue to draw their full salary, lived in a nice house with a garden, that was a very different life experience to those who had lost their job, those who were living in overcrowded accommodation with no outside space, with family members, and just unpacking that a little bit more. So we've highlighted some enormous variations here. And it's made me think a lot about intersectionality theory, where we think about the complex interaction of different variables, those of race, class, and gender, and how they actually contribute in overlapping and interdependent ways to increase discrimination and disadvantage. We've been very clear about wanting to engage with the public and with people who are experts by experience throughout this process, and to particularly target vulnerable groups. So we've had a number of blogs where we thought about young offenders, refugees, children and young people with autism, people about to give birth. We've been involved in radio and television interviews. We've made films where children and families have shared how you can use the experience of play to help children with emotional regulation. We've produced 14 policy and guidance papers, and we've got 4 still in production and another film. We've been thinking carefully about developing policy and guidance, and there's some of the details there, particularly thinking about drawing on expertise within the BPS for those with learning disabilities, for older people, and for those young people in the school system. We've been thinking about promoting resilience and recovery, giving support to frontline workers, looking at issues to do with bereavement. As Ingram just mentioned, the remote assessment activity, and what we're currently working on is shielding. This morning we had a working group for those working on the shielding outputs, and we were really thinking about how important it is that people understand that the anxieties they're feeling are completely adaptive, that we're living with complete uncertainty, that people are having to do risk analysis, which is based not only on their exposure to risk, but also multiple exposures, the people that they do come in contact with, the issues of families that have been shielding vulnerable adults or other vulnerable children, where siblings are being encouraged to go back to school. And throughout this process, what we've really been concentrating on is trying to develop a really effective resource bank for professionals. So these are resources not just for professionals, but they're also for families, for children and young people. And the evidence base that we're able to draw on from our psychological practice has informed all of these. So that's the end of my presentation. David, I see you popped up.
I have popped up. Thank you. That was just an absolutely fantastic presentation, Vivian. A really interesting and engaging. And it's I think one thing that strikes me is that when we do these pieces of work where we bring people together from quite different domains of practice, these broader themes that you've really drawn out so clearly in your presentation really do seem to rise to the surface more. And I think we can see, and I think we see a lot of the themes that you've mentioned here really do cut across so many domains of psychological practice, that I think that's been such a strength that's come out of this. And thank you for illustrating that in your presentation. I know within that work stream you've done such sort of some really detailed specific work, but also you've been able to draw out these more wider themes, which hopefully we'll come back to, and we should have a little bit of time for discussion, but to enable that I should move on. So thanks so much.
You say that we've been delighted that some of these resources and materials have gone into the Department of Education and actually are developing thinking and different ways of responding in the future. So it's been wonderful.
Fantastic. Yeah, fantastic. Thanks, Vivian. So our final speaker is Darrell O'Connor, who has led a piece of, who's the deputy chair of the COVID coordinating group. So he's been a great, made a great impact in that sense, particularly when I myself had COVID and he had to step in as chair, which I was very grateful to him for. But he's been in a great, sort of made a great contribution right from the very beginning, when he and I sat down to try and work out how we're going to get this thing off the ground. So, you know, it's a chance for me to thank Darrell again for that. He's also led a piece of work which again, we've really tried to make sure we cover practice and research, and we've pulled together, or when I say we, Darrell has pulled together a piece of work that he's engaged very widely across the discipline of psychology to bring this piece of work together about trying to start the discussion on psychological priorities for research. How's it going? Oh, right. Great. So I'll pass over to Darrell. Thanks, Darrell.
Thank you, David. I appreciate that. And thank you, David, for your sterling work over the last 3-4 months on leading the work stream, all these work streams. So what I would like to do over the next 15 minutes is talk to you about the work of the research priorities stream, and particularly about a position paper that has just literally been accepted yesterday in the British Journal of Psychology. So in particular, let's start with a little bit of context. So what we know is that COVID-19 is inextricably linked with human behavior. And what we also know is that the collective and individual responses to COVID-19 and the countermeasures have fundamentally changed how society operates. So it's changed how we work, how we educate, how we parent, socialize, communicate, and travel. And actually, the effects of the pandemic we already know are profound, and they're likely to shape human behavior long into the future. But from my point of view, what's interesting is that we know that the impact will extend beyond mental health. The effects of mental health have been extraordinary, but it will also impact on every other aspect of how we engage in our daily lives. So I also think it's important to highlight that COVID-19 as a pandemic is unique. The ongoing risks associated with COVID-19, things like the large numbers of people who remain, who are infected who remain asymptomatic, the impact of the countermeasures on societies, and also the likelihood of second or third waves, and even as we saw in Leicester yesterday and today, the idea of a local lockdown. And the other thing which I think makes COVID different to previous pandemics and epidemics of a similar nature is its global reach. It is definitely unique in that regard. But I think in the broader context, COVID's impact should not only be measured in terms of biological outcomes. So to our mind, it should be also assessed in terms of economic, health, psychological, and social consequences. And for that reason, I believe, and many others believe, is that psychological science is integral and it's got such a key role to play in helping societies recover from the pandemic, not just in the context of mental health, which is hugely important, but in the broader remit of other areas of our life. So what we wanted to do in this particular group was we wanted to highlight the many different ways in which psychological science, its methods, approaches, and interventions can be harnessed to help recovery from the pandemic, both in the shorter term, the longer term, but also in the future if additional pandemics come our way. So what we did was we convened the BPS COVID-19 Research Priorities Group, specifically with the initial aim to produce a position paper. And the aim of the position paper were threefold. So the aims were, first of all, we wanted to frame the breadth and scope of potential contributions from across the discipline. We secondarily wanted to assist psychological scientists in focusing the resources on gaps in the literature. And finally, we wanted to help funders and policymakers to make key decisions and identify that what we felt were important priorities to help us all emerge from the acute phase of the crisis. So what do we do? So we set about, first of all, identifying an expert panel. So we put together an expert panel which reflected the breadth of the discipline. So this was a group of 9 colleagues who all had expertise in different areas from social psychology, educational, health, cognitive, etc. And what we did was we used what's known as an iterative expert consensus procedure, which in time, because of the time urgency of the pandemic and needing to operate and swiftly, so we weren't able to do in-depth analyses. So this procedure allowed us to work very closely, and we met regularly over a period of 4 weeks. We went for every couple of days for at least an hour face-to-face to have intense discussions about what we felt were the different priorities. But also we then enrolled a larger group of advisors, an advisory panel with some international input, as you'll see in a second, just to identify other issues that we may have missed and also to get additional feedback. And then the third thing we did was we also developed a very brief pulse survey to identify what other psychological scientists believed were important, and also just to get feedback and some qualitative information as well. And thankfully, 539 people responded to that. So if you're one of those, thank you very much for your time and effort. And here is the group of experts. So as you can see, this was led by myself as chair, Chris Armitage as co-chair, and we had a range of colleagues then from different institutions, but again, crucially representing core areas of the discipline. And we're also supported well with colleagues, Lisa Morrison-Coulthard and Deborah Malpass from BPS. And as I said, we also had a broader group of advisors. So this advisory group, and this entire group together, we had 29 colleagues who, and again, you can see the full list at the end, but representing a range of institutions and diverse backgrounds, as well as different areas of the discipline and different methodological approaches. And then we also enrolled the help of Dan Schechner at Harvard, and hidden behind me, at least on my screen, but you might be able to see it in yours, was Susan Fisk from Princeton. And again, so over the period we had these 3 sources of information, but this was to inform and lead us in our thinking about our position paper. So let's give you a little bit of very brief feedback onto what the survey showed. So in the survey, we asked respondents to rank order the top 5 research priorities in the different areas that we, as the experts, so-called experts, had defined. And what we find here, I'm not going to go into a lot of detail, but you can see on this slide, we've got 8 broad areas from biological, these are alphabetical order, clinical, right down to social. And you can see, for example, if you look at the social, you've got things, the top priority in that area was what makes people adhere to anti-COVID measures. So what we were wanting to do here was we wanted to use these particular results at the area of, the core area of psychology to inform our thinking of the research domains, the research priority domains. So that fed into our thinking. And again, you can read a bit more detail on the qualitative findings of a report that will be released soon by Lisa Morris and Coulthard. But what was the other striking outcome of from the survey? What were the qualitative data? And one of our, we had a brief look at that before we did a more detailed thematic analysis conducted by Lisa and colleagues at BPS. But what the key message was, and it again reflects what Vivian had said earlier and others and David before, was the key role of inequalities. And it was central to all of the different domains that we were working towards. And it's this notion that COVID-19 is not a single pandemic. It's better seen as multiple parallel pandemics. So this is a notion that the impact of COVID, both psychologically, health and behaviorally and all the other ways, it will impact differently in different groups. So there's groups which are much more vulnerable than others. So one of the big things and the key messages that we have entered in our paper, but which came out of our survey and our own work in the core group, was that psychological scientists really need to consider things like ethnicity. We know that's a hugely important issue. Socioeconomic status, health, physical health, long-term conditions, age, sex, the role of social exclusion and social support. But again, reflecting on what Vivian had said in the previous presentation, the issue of intersectionality became really quite prominent in the analyses that we were looking at. So again, it's crucially important that future research priorities consider inequalities across all the different areas. So that brings me to the central focus of this particular position paper. So for all this different information then collided into these 7 COVID-19 research priority domains. So these are broad domains that we felt should help both psychological scientists and funders and other interested parties to try and help us recover from the pandemic. And these are just very briefly summed up in this particular slide. And as you can see, so we've talked a lot about mental health. So we know that mental health is a serious long-term, short-term and long-term priority for COVID-19 research. So we need to do more work in that area. But there's also the areas of physical health. We don't know things like how it impacts in the brain, as you'll see in a second when I decompose these in a little bit more detail. Children and families, the impact of COVID in that area is hugely important. Steve talked about it earlier, Steve Reicher, the impact and understanding further about groups and conflict, the impact of COVID on educational practices and how we work. And then the other area, which as you'll see, it's our number 7 priority in the following slides, is the understanding more about behavior change and adherence, because that's been central platform to so much of what we've been exposed to thus far in this pandemic. So just very briefly, I wanted to show you a couple of slides which unpackage our 7 research priority domains. So as you can see here, number 1 is groups, cohesion and conflict. So our feeling as the key core group, supported by the other areas of information advisor group and our survey, is we really need to understand this in more detail. And also, this is not just the negative consequences, but also the positive consequences. We've seen a lot of community solidarity and resilience in this pandemic, but we need to understand that further. Work, we are all working differently now. And this is also very important. And then also we've got children and families. And then if we move on, there's just to briefly show, I think David's right suggesting my time is limited. So we also have educational, mental health, physical health and brain, and behavior change and adherence. But there's a couple of things I want to finish by talking about. And that is identifying the sheer importance of us as psychological scientists. Psychological scientists have this amazing toolbox. And the upper part of this slide, you can see we've got all these incredible methods and approaches that we're harnessing already. And we need to do that in much more detail. But I want to just flag this final bottom part of the slide, and then I'll show you a couple of very brief take-home messages. We as psychological scientists have been leading the way in open science and high quality, rigorous research. So whilst we respond to the pandemic, we really need to consider both maintaining these standards, the high quality research in order to deliver well on these priorities. And now very briefly and finally, here are my very simple take-home messages. We should pay attention to these research priority domains, but also look beyond them. These will help with the recovery. Let's not forget about the role of inequalities. We need to really work in much more large cooperative ways and develop research consortia in order to really help us meet the demands of responding to this whole pandemic. But then the two final things are, it is time, as Angel had said earlier, for us to have a chief behavioural scientist. But just to reiterate, whatever we do, what is important going forward is maintaining the high quality, open and rigorous research that we've been doing over the last number of years. So thank you very much. And again, the paper will be available very soon, and you will be able to download it free, I hope, on the website very soon. Thank you very much, David, for interjecting there and speeding me up.
Thank you very much, Daryl. That's really a fantastic piece of work to bring people together, and a fantastic output that, as you say, people should be able to access very soon. I think, yeah, I mean, I'm more familiar with the sort of challenges of bringing practitioners together, but I know there's challenges in bringing researchers together and getting them to agree on things. And I think you've done a fantastic job at, again, drawing out those themes. And again, we can see the commonality between themes, between practice and research as well. So I think you've done a fantastic job there. And thanks for a very kind of clear presentation. We've got about 7 minutes. Daryl predicted we'd have 10, so you were pretty accurate. We've got about 7 minutes to deal with a couple of questions that Lisa's got from the chat. So can I get all the panelists to come back on screen so people can see us all? I mean, we won't get through all of them. And well, yeah, we won't even get through 3, I don't think, if we all say something. But I mean, one of the things that does strike me is these common themes. And one of the questions does speak to that. And I mean, we've talked about the impact of inequality and how the virus is actually, you know, not affecting everybody equally. And one of the questions was, do you think that more advice should be given to the public on diversity, e.g. for how the pandemic affects deaf, blind people, difficulties in social distancing, but even more generally than that, do you think there's been enough I mean, we've been hearing a lot about sort of, you know, the social distancing 2 meters and the messages, stay alert. You know, should we have been having messaging about staying alert to social, the social inequalities within the COVID pandemic? So I don't know if a couple of people want to just make some brief comments on that.
Maybe perhaps I'll pick and maybe Lane can say something. I think, Dave, that's a really important point, certainly from the work that we've been doing in our work stream, and also I'm sure Angel will want to comment as well. It was hugely, you know, it's an area which I think we've got to late. And Vivian's point in her slides about the idea this is impacting us all equally is completely untrue. And we need to really get on top of that sooner rather than later.
Yeah, no, I agree what the question was. Yeah, I think it has been one of those things that you just kind of take it for granted, and you just assume that everybody has equal access to all the information, and you just assume that everybody understands things the same and everybody can, like I said, access everything. But it's not, especially with the deaf community, they haven't been given access to anything, and they've kind of had to rely on local, you know, deaf charities and interpreters to make sure that information is out there, because like I said before, it's just not been on anybody's radar, especially our government, to make sure that access is, you know, being given to everybody. So yeah, I think more needs to be done to make sure that information gets out there to the public, because it's okay giving it to other professionals, but the wider public still need to have access, and they need to understand how things might work as well.
It strikes me that that links with Steve's talk this morning about what government's role is in a crisis to sort of facilitate the community response. And you know, by definition, the government is in a position to do that, or sort of public authorities are in a position to do that, because people individually don't necessarily know what the particular challenges on the deaf community or other particular community. And so a role that really only public authorities can play is helping the community become more aware of those, and then mobilizing that support. I don't know, Vivian, if you want to add anything to that.
Yes, I was going to say, I think as so many of us are actually practitioners, psychologists working with these communities, it's important that we're listening, that we're hearing what the challenges of the issues are, and actually promoting the voice and giving voices to these communities. And in such, the engagement with public is a key part of our role in developing policy and shaping policy. So I think it's in partnership with all the communities that we've identified as particularly weak and vulnerable in this context.
Yeah, no, that's a really good point. And when I say only government, I mean, it's not only government can do it. I think bodies like the BPS have, as you say, have an opportunity and an obligation to do that, and to kind of help government along it on its role as well. But no, I think that's really important. I think sometimes we don't pay so much attention to our role in terms of the public in the BPS. So I think that's a really helpful point. We've got a couple of other questions. I'll move on to one more specific one, which I suspect Ingram will take, but it's, do you think, no, hang on, I've just read that one. How does one deal with the issue of confidentiality when assessments are done virtually, because of the supposed lack of privacy with online assessments?
So I read that, David. I mean, I suppose that what I was concerned about and talking about was the issue about making sure that we understand the risks to which we are both exposed in these interactions. So there's a confidentiality issue in terms of the normal confidentiality that I enjoy about my family life in terms of my interactions. And if I'm conducting appointments from home rather than from an NHS base, then I'm further exposed. I also think the families that we see are not necessarily aware that we're not only looking at them, but also looking at the home environment, and no doubt making judgments, sometimes appropriate judgments, about the risks to which they're exposed. I think the fundamental principle is one of informed consent, that we must make sure that people understand that when they join an online video conference, whether it's an NHS conference or a Zoom meeting, that there's a risk that they stand up and someone discovers they were wearing shorts. Or I don't mean to trivialize it, but these are risks that we've all kind of experienced sort of day to day in terms of the intrusions into our lives. And I think that clearly in the clinical environment, some of those are non-trivial. So I think the issue is one of informed consent, and I think I would see confidentiality sitting within that sort of broad spectrum around there being obvious limitations to confidentiality and the importance to protect our clients and their families, and to engage in appropriate safeguarding procedures, but we need to manage the risks and inform our clients about those risks.
Okay, we've got 1 minute remaining, and so I'll deal with the third question, or see who wants to answer this. Isn't behavioural science just psychology? Why the differentiation? I suspect Angel might have an answer to that one.
Yeah, I'll answer that. Behavioural science is an umbrella, so it's lots of different disciplines that will then inform, lots of different disciplines that look at the influence of behaviour, or what influences behaviour. So it includes psychology, epidemiology, sociology, geography, law, politics, economics, and the behaviour aspects of biology. So it is an umbrella term, but psychology has quite a big stake in that umbrella. Hope that helps.
You could say we're the sort of spoke that holds the umbrella, the bit in the middle, maybe.
Economists might fight us for that, but
I can say that because okay. Well, Claudia's just popped back, so just for me to say thank you to all of the panelists for fantastic talks and contributions to this symposium. Judging from the comments, I think people have found it helpful. So thank you for your contributions. And Claudia, you're going to just tell us a bit about after the break.
Yeah, so thank you very much for that, David, and for everyone else there. There was a really impressive amount there packed into not that long a time. And also, I think there's such an impressive range of things there that of different ways that psychology has been contributing, and I think a lot of people in the public would have no idea that psychology can contribute in so many different ways. And I certainly didn't realise that so many individual psychologists had been. I knew loads of work had been going on over the last couple of months. I didn't know that so many different individual psychologists had been involved and that so many had responded. I think that's amazing, really, really impressive. So what we're going to do now is to have a short break to give you an opportunity to make a cup of tea or read your emails or just rest. Having just written a book about rest, I know how important breaks are. So it's very good that we have this 15-minute break now where you can do something restful. Remember that you can be inputting your feedback into Slido on the session that you've just had there. When we return from the break at 3 o'clock, it's just a short break, a really interesting topic, because we're going to be hearing from Paul Slovic for his keynote on risk and decision making, which is due to be fascinating. So do be back at 3 because you won't want to miss a moment of that. Thanks.